The last time we did a topic on irritable bowel, inflammatory bowel disorders. Just like to recapitulate that particular topic, something that you have to understand in this new curriculum is all these years we used to do inflammatory bowel disorders where we have drugs like sulfasalazine, then balsalazide, then you have drugs like antimetabolites, like anti-cancer drugs like azathioprine, methotrexate, right? But nowadays, apart from giving treatment for inflammatory bowel disorders, where you also have tumor necrosis factor alpha, infliximab, adalimumab, they are similar to the drugs which we have seen in rheumatoid arthritis. So they are all, immune system related drugs. But today, I come to a very, very important topic. They have included this particular topic in your curriculum this time because a lot of people have suffered from this particular syndrome. I'll start straight away with this particular case scenario. Here, this patient was having a recurrent abdominal pain at least 3 days in a month, or at least some pain or the other within 3 months. And this patient has been diagnosed that, there is no structural, there is no biochemical abnormality. And the patient always come with one of the following symptoms, where the pain or the discomfort in the abdomen is improved with defecation. And the pain abdomen or the discomfort in the abdomen is always associated with a change in frequency of stool. And an onset of such cases are always there because there is a change in the form of stool formation. Some patients have also undergone biopsy, and then they want to know why they have these kinds of symptoms. And most of the patients, if you look at this case scenario, they always have a past history of some mood disorders. That's why we have taken the gastrointestinal tract system disorders nowadays after we have finished CNS, because they are interrelated. And then depression is one of them. They have a constant persistent feeling of sadness. They don't have any interest in life. And because of this, it affects how you feel, think, and behave. And pathophysiologically, it can lead to irritable bowel disorders. These patients also come because they have suffered in some form of a disease known as fibromyalgia. This fibromyalgia is a musculoskeletal disorder. And then it is always accompanied by weakness. It is always accompanied by lack of sleep. Okay? So patients who come with irritable bowel syndrome, apart from abdominal pain, apart from abdominal discomfort, if you take a good past history, some of them will always mention depression, some of them a disease called as fibromyalgia, or they may come with a past disease of asthma. In such cases, we broadly describe this particular syndrome. It is not one particular symptom. It is a group of functional bowel disorder. Usually they come with chronic abdominal pain, and if you dig into the history, they have some issue, mental issue, one way or the other, or a musculoskeletal disorder, and some of them come with GERD or bronchial asthma. And this particular irritable bowel syndrome has constituted a major health problem. That's why the curriculum now has changed that, you should be able to diagnose and you should be able to treat this particular problem if a patient comes to you. And usually it's more frequent in women. They will always come with abdominal discomfort and pain. That is the first symptom. They may also come with bloating, mucus and stools. Sometimes they come with diarrhea, constipation, or their patient will come with alternation between diarrhea and constipation. And if you go into the history, past history, they are suffering from depression, They have some sort of stress and they are always anxious. In such cases, if they come at a history of 3 times per month or 3 times, in a span of 3 months, and they keep coming to you within a period of 6 months, then definitely these people should be categorized into irritable bowel syndrome. And you can subdivide them like this. It could be diarrhea predominant, it could be constipation predominant, or it could be something alternating between diarrhea and constipation. If these patients come, you have to understand what exactly is the pathogenesis. When we talk about anxiety, when we talk about mental depression, we have already come across this particular neurotransmitter, 5-HT3 receptor, which is mostly present in the GI tract. And then because of this 5-HT3 receptor, its action in the GIT, where it causes contraction of intestinal muscle, it releases fluid into the intestine. So you don't want all these actions in a patient suffering from irritable bowel syndrome. Why I've given to you the role of neurotransmitter is this. If you don't understand what is the pathology behind, if you don't understand what is the neurotransmitter involved, it's very difficult if you give out drugs and the patient asks you, what drug is this? Okay? So again, I'm repeating, 5-HT3 receptor, they control sensation, contraction of intestinal muscle, and the release fluid into the intestine. That's why you may get alternating between diarrhea and constipation. In this case, you can always slow the intestinal transit time, decrease the fluid content in the intestine or the secretions into the intestine, where you give them 5-HT3 antagonists. You give them 5-HT3 antagonists. Can anyone tell me one 5-HT3 antagonist? 5-HT3 antagonists. So remember these drugs that can be used there. But I'm giving you other drugs which can be used today. Okay? We have also mentioned in when we were doing antiemetics the role of neurotransmitter 5-HT4, and we say 5-HT4 is so important, 5-HT3 is so important, 5-HT4 is so important because 5-HT4 it causes both relaxation and contraction of circular smooth muscle. It induces small bowel and colonic fluid secretion. And then if you give drugs which are agonists to 5-HT4, they will accelerate the gastric emptying. And then they accelerate the bowel transition, the movement. That's why they are also called as prokinetics. So these two subtypes receptors of serotonin, one is the 5-HT3, one is the 5-HT4. 5-HT4 we are using agonists because in a patient suffering from constipation, in a patient suffering from intestinal paralysis, you would like to accelerate the gastric emptying time. For a person who has so much of contraction, you want to stop it. You want to stop the intestinal contraction by giving antagonists to 5-HT3. So when we look at the management of irritable bowel syndrome, not inflammatory, this is irritable. Okay? When I write IBD, I mean inflammatory bowel disorders. When I write IBS, it means irritable bowel syndromes. So the management means, first thing, you have to educate the person. You have to reassure the person that, okay, you may be having stress, you may be having anxiety, but it is all right. We will have a treatment for this. And you have to have a dietary modification. If you're having constipation, you have to have high fiber diet. And then you give a symptomatic treatment. Don't forget that. For a patient suffering so much of mental issues, you can also go for psychological and behavioral options. Whatever be the case, these goals which you want to manage the patient of irritable bowel syndrome, they have to be realistic. They have to be met. Otherwise, the patient will lose faith in the healthcare system. So coming to drug treatment, the first drug is dicyclomine hydrochloride. Where have we heard this drug? Dicyclomine hydrochloride, clidinium bromide, chlordiazepoxide. Where have we heard these drugs? They're anti-something. Dicyclomine, we have just finished the internal examination. Martina, can you tell me, where have we heard dicyclomine? Where have we heard clidinium bromide? These are anti. Remember anticholinergics? Am I still audible? Yeah, Payal will be answering. Yeah. So Mrinmoy, say something. What could it be?
Dicycloamine is an anticholinergic, whereas chlordiazepoxide is a benzodiazepine.
Benzodiazepines. Very good. So what could be the rationale? Why we are combining clidinium bromide with chlordiazepoxide? In a patient suffering from irritable bowel syndrome, why we are combining one antispasmodic anticholinergic with chlordiazepoxide? We are combining with chlordiazepoxide, yes or no? Clidinium bromide with chlordiazepoxide. If we look at the symptoms, if we look at the past history of the patients with IBS, they always come with mental stress. That's why you always have to keep a very minimum benzodiazepine, minimum acting benzodiazepine like chlordiazepoxide for anti-anxiety. Anti-anxiety. Is that okay? Is that understood? Then you have these two broad drugs which have come out nowadays. One is tegaserate and another one is allocetrone. Tegaserate and allocetrone. Before I go into this, if a patient comes with diarrhea, irritable bowel syndrome presenting with diarrhea, then you can give antidiarrheals. I think you remember these: loperamide, diphenoxylate plus one anticholinergic, atropine. If a patient is coming with constipation, symptoms of constipation, and you have diagnosed the patient suffering from irritable bowel syndrome, then you will give magnesium sulfate. I hope you remember these drugs used in constipation: magnesium sulfate, lactulose, or a stimulant purgative, say like Xena or castor oil. If none of these drugs work, then definitely we have to treat the mental issues thoroughly by giving tricyclic antidepressants or the serotonin, selective serotonin reuptake inhibitors. These are also antidepressants. Okay? I'm feeling a little bit scared to ask question again, so I'll just go on. Now, let's go into this allocetrone. Allocetrone, like ondansetron, granisetron, tropisetron, these drugs are purely antiemetics. But this allocetrone has been brought out because it is a 5-HT3 receptor antagonist like ondansetron, like tropisetron. But then it is so good in its responses to pain and contraction of the intestinal muscle. So it controls these pain. It controls the contraction of the intestinal muscle. Okay, so it doesn't allow pain. It doesn't allow watery diarrhea. Understand? Again, I'm repeating. 5-HT3 receptor antagonists. We have many. We have granisetron. We have ondansetron. We have tropisetron. But these are not used in IBS. This particular drug, allocetrone, has been taken to use in IBS because it is the one that controls the pain and controls the fluid secretion in the intestine, so it helps in abdominal pain as well as in diarrhea for patients suffering from irritable bowel syndrome. Next drug we have is the tegaserate, which is the opposite action of allocetrone. Allocetrone is a 5-HT3 antagonist, whereas tegaserate is a 5-HT4 receptor agonist. If you remember cisapride, if you remember ipsapride, if you remember levosalpiride, they are also 5-HT4 receptor. And if you remember one powerful antiemetic, metoclopramide, Metoclopramide has got a very nice anti-emetic and prokinetic action. Why? If you want its anti-emetic action, it works as 5-HT3 antagonist. If you want its 5-HT4 action, it works as 5-HT4 receptor agonist, so it helps in prokinesis, meaning it increases the intestinal movement. Similarly, this tegaserol is similar to metoclopramide. The only difference is it does not inhibit 5-HT3, so it does not have anti-emetic action. Rather, it is an agonist at 5-HT4, so it helps to stimulate the peristaltic reflex and intestinal secretion of the GIT. Okay? Because it quickly clears out the bowel movement, it reduces intestinal pain, it reduces the pain sensing nerves, therefore the abdominal pain itself is being inhibited. So these two important drugs have been brought out nowadays to treat purely for irritable bowel syndrome. One is allocetrone. The mechanism of action is 5-HT3 antagonist, whereas the tegaserol is 5-HT4 agonist. They have got different actions. Please remember that. So irritable bowel syndrome is a chronic medical condition characterized by abdominal pain. Sometimes patient come with diarrhea, sometimes patient come with constipation, or alternating between diarrhea and constipation. They always come with a feeling of fullness of the abdomen, that is bloating. And if you ask about their stool content, they will say they have passage of mucus and incomplete evacuation, stool evacuation. So different patients require different therapies, whether you want to give them 5-HT3 antagonist, or you want to give them 5-HT4 agonist, or you want to relieve the diarrhea for symptom treatment, or you want to take away the stress which the patient is having by giving them chlordiazepoxide, clidinium combination antispasmodic, or you treat them by giving antidepressants like tricyclic antidepressants or SSRIs. Overall, they have to have a lifestyle modification. If they're having constipation, they have to take a high fiber diet. If they're having diarrhea, they have to remove all the spicy foods, okay, fatty foods. If they are smoking, they have to stop smoking. If they are drinking alcohol too much, they have to, cut down the intake of alcohol. And stress is number one, that you have to insist that these patients get behavioral counseling. Any question till here? So now I go to another topic, that is biliary diseases. All of you will be, at one point or the other coming across patients who suffer from biliary diseases. Either they will come with cholelithiasis, meaning stone in the gallbladder, or inflammation of the gallbladder known as cholecystitits. Okay, so cholelithiasis and cholecystitis. Now, if they come with cholelithiasis, please remember there are two stones, cholesterol stones making up majority, and pigment stones around 50%. Okay, and patient always come, most of the time they come with a biliary sludge. Now, if you go to Davidson or textbook of medicine, you will find that there is a nice explanation given on biliary sludge. It is nothing but a gelatinous bile containing calcium bilirubinate granules. Okay, sorry, it's not granules, it is granules. And then the simple thing for a biliary sludge is not cholecystectomy, but you would like to, dissolve the gallstones, and this is where pharmacology comes to take in a place, where you will give quinodeoxycholic acid. Please remember these drugs: quinodeoxycholic acid and ursodeoxycholic acid. Okay, sometimes a mini form of surgery like extracorporeal shockwave lithotripsy can be done to break down those big stones so that they can be dissolute. Okay, they can go into solution. So these two drugs, you please remember, they are bile acids, oral bile acids for dissolution of cholesterol crystals in biliary sludge. One is chenodeoxycholic acid, another one is orthodeoxycholic acid. Now this is regarding, you know, biliary sludge. Then sometimes patients come with cholecystitis. I will not go into the clinical features and the Charkov triad which you will be taught in surgery. Okay, straight away you will find that LFT, amylase, all these things. No, you will have to investigate for a patient suffering from cholecystitis. But the paramount investigation is ultrasound. Okay, after you have come to a diagnosis that this is a case of cholecystitis, then you would like to do a treatment. If it's an acute cholecystitis, patient will come with pain here, okay, in the right hypochondrium. I've had this attack and it's so painful. And the best analgesic, don't say please give morphine. It's very sad. When you're asked, in acute cholecystitis, what will be the analgesic you'll be giving? And everyone starts saying, morphine. Very sad. Because morphine is contraindicated in unexplained or undiagnosed abdominal pain, or in biliary colic, it is contraindicated. Please remember this. So the best analgesic in acute cholecystitis is to give diclofenac. What is diclofenac? What is diclofenac? Or nowadays we have better ones like aciclofenac. What drugs are these?
NSAIDs.
NSAIDs, very good. Non-steroidal anti-inflammatory drugs. And please don't say also among all the NSAIDs that I will give number one aspirin, because aspirin is not given for some form of inflammation. Usually aspirin is given for other indications. So out of all the NSAIDs, you can give diclofenac, you can give aciclofenac. And if you go to opioid types of analgesics, then you can give betadine. See, betadine. And cholecystitis always come because there is an infection in the gallbladder. Some form of infection is there. So you always have to add one antibiotic. Okay. In the next 2 to 3 class, we'll start this major topic, that is antimicrobials, and it's going to be very interesting. Yes or no? You agree with me that antimicrobials are going to be very interesting? Now, acute cholecystitis, this is how you manage. You will give analgesic, you will give antibiotics, and then you will give IV fluids, because the patient will not be able to take anything, and you have to give supportive treatment with IV fluids. But if this turns out, if there is no resolution, if the patient cannot tolerate cholecystitis for a long time, it doesn't resolve, then it goes on to a stage known as chronic cholecystitis. In this case, please don't say I'll still give analgesics, which is being done all over in Shillong, and it's very sad. They still keep on giving diclofenac because the patient refuses to go for ELC. They don't want elective laparoscopic cholecystectomy. They don't want. They are so scared of surgery. So they go on with acute cholecystitis, being treated with aciclofenac or betadine for 1 year, 2 years, and ultimately they end up with cancer of the gallbladder. Is this okay? So when we are talking about bile salts, bile acids, you remember chenodeoxycholic acid, orthodeoxycholic acid. They will dilute the salt, the bile acids, okay? And then if you're talking about acute cholecystitis, number one, you have to know to give, and then chronic cholecystitis. When I talk about antibiotics which are being given in cholecystitis, the best is ampicillin, the best is your amoxicillin, and then nowadays we are being given intravenous ceftriaxone. Okay, these are cephalosporins and beta-lactams antibiotics. So we'll be doing about this separately. Any question? Next, I go to acute pancreatitis. It's very sad that most of our graduates, they miss out on this particular. Okay, Albert is joining us now. Okay, they miss out on the acute pancreatitis management, and it's very sad. When the patient comes with acute pancreatitis, they always say it's a belt-like abdominal pain. They'll say pain here. I don't know whether you can see me. They'll say pain like this. And then there is vomiting, there is distension of the abdomen with tenderness, okay? And when you take a stethoscope and you listen, there is no bowel sound, similar to peritonitis, okay? Then there'll be tachycardia, blood pressure, and everything. Patient usually comes in shock. And then if you look at an X-ray, you will always find a left-sided pleural effusion and hemoperitoneum, that is Cullen sign. You'll all be doing this in surgery. But it is so important that you have to know what are the clinical features of acute peritonitis and acute pancreatitis, and you have to know how to manage them. Don't say I'll manage at home. Never manage at home. And it should be nil orally, because you want to put the pancreas to rest. You have to give analgesia, okay, analgesic drugs. You can give diclofenac, aceclofenac. Betadine is the most important. Then, okay, when there is absolutely no bowel sound, no movement, then you try to put in a nasogastric tube, okay, or if the patient is vomiting too much, okay. If there is pulmonary shock, you will have to treat for pulmonary complications or shock, renal, metabolic, dopamine is there, noradrenaline is there, so many of those drugs. Now, most of these patients who are suffering from acute pancreatitis, they come with some form of a GB stone which is obstructing at the neck, okay. And in such cases, if it is detected at the time of presentation, then these patients have to undergo immediate cholecystectomy to remove the gallstones. And then ultimately, if there is infection, you have to give antibiotics. So today is a class where I'm giving you how to manage, how to manage, how to manage. If a patient is presenting a symptom like this, if a patient coming with clinical features like this, it could be irritable bowel syndrome, it could be cholecystitis, cholelithiasis, it could be acute pancreatitis. And if it is not acute, patient also may come with chronic pancreatitis. And mind you, this one, chronic pancreatitis, it will mimic irritable bowel syndrome, because the patient will come with chronic abdominal and back pain. But if they mention again a belt-like pain, okay, then or acute pancreatitis, a recurrent one, then you have to understand this. Or a patient suffering from diabetes, already in insulin, already on oral hypoglycemic agents, and they come with pancreatic pain. Sometimes patients come with intestinal malabsorption and steatorrhea, fatty things in the stools. Then abnormal liver functions, ALP, SGLP, ALT, all these are abnormal, then you have to think. Then sometimes there is a bile duct obstruction, the patient presents with jaundice. So these are the chronic pancreatitis symptoms. You have to remember them. Octreotide. We have not done this particular drug, but octreotide can be used to reduce pancreatic pain. It is a CK. It interferes or it blocks the cholecystokinin release. CCK. Octreotide. Please remember this drug. And then if the patient is alcoholic, all those taking very high lifestyle with so much of protein, so much of fat diets, tell them to restrict. Okay. Then you can always go again to diclofenac treatment, aceclofenac treatment. Sometimes you have to give nitrates and spasmolytics, antispasmodics. Then a patient needs to go on insulin as well as H2 blockers. These are the how you will treat chronic pancreatitis. Please go through all this principles and practice of medicine. There are so many questions which are related from pharmacology to. So if you ask your seniors who are in the final year, they'll say, oh, it's all related from pharmacology to medicine to surgery. Again, pharmacology, medicine, surgery, all these things come. There is a nice textbook, Schleisinger's textbook of GI disease. There's a PDF, you can download that. And then KD Tripathi for anti-diarrheal, anti-drugs for constipation and all that. This is a disaster. Everybody didn't know what to do with this. This question was really disastrous. Anaphylactic shock. Okay, when we have done in the practicals, Yes or no? We have done in the practicals. We said you will do an intradermal testing of penicillin. If there's induration, if there's a reaction, because the patient suddenly will develop rash, patient suddenly will develop hypotension as well as dyspnea. So how the first and foremost thing is to prepare adrenaline, either 1:1000 dilution or 1:10,000 dilution. If it is 1:1000, you're giving IM. If you're giving 1:10,000, it's IV. We have talked about this again and again. Apart from giving adrenaline in anaphylactic shock, you will also have to give antihistamines like chlorpheniramine. They're not given orally. None of them are given orally. They are always given parenterally. Similarly, one corticosteroid, hydrocortisone, you have to give to the patient. So number one drug is adrenaline, number two drug is antihistamine, number three drug is hydrocort. Some books they also mention H2 blocker, not only H1 blocker, they also mention H2 blocker. Following this question, we have this. Okay, this is a classic KD Tripathi question. Adrenergic drugs, some pressor agents, some cardiac stimulants, some nasal decongestants. This one was a repeated question. Okay, nasal decongestant was repeated. In the very next question, name some nasal decongestant. If you had written here, it could have been written there also. Some bronchodilators were not mentioned by anyone. Uterine relaxants were not mentioned by anyone. Then CNS stimulants also some mentioned. So this particular 3 marks question was gone. Okay, this question was gone for almost everyone. Nasal decongestants because they are vasoconstrictors, okay, alpha effects. That's why you're giving phenylephrine. This one, so many I have answered. This is. I will not go in the part 2 one because phenytoin has already been discussed. Then levodopa has already been discussed so nicely. So I will not go to that. So these are the questions from part A, where it has been missed out so badly. Autonomic nervous system is very tough in pharmacology, and it's a tough thing, I know, but then it has to be overcome at some point or the other. Thank you everyone for listening.